Hello, everyone. Welcome. We'll get started in just a minute to allow more people to get signed in. But as we wait, I'd like to introduce myself. My name is Madison Burnett, and I'm a BCBA. I lead our professional development program, and I'll be available to support throughout the workshop. In addition to that role, I work alongside other BCBAs on our clinician-led recruitment team, and I support in the effort in recruiting quality professionals to join our team like you. Next, for some housekeeping information. About contact hours and for CEUs if you are looking to obtain either one. For those seeking contact hours or CEUs for this presentation, there will be a post-webinar quiz and survey over the content of today's presentation, and there will be no code words. So again, there will be no code words stated, but it will be a review over what Ariel is going to be presenting on today. We will send out this post-webinar quiz within the last 10 minutes or so of the presentation. We will be leaving the chat open, but please post any questions you would have in the Q&A so we can make sure that they are seen. All right, and now I'd love to introduce our speaker. Dr. Ariel Kornblum is a New York State licensed psychologist, a board-certified behavior analyst, and a New York State licensed behavior analyst. She received her undergraduate degree in psychology from the George Washington University and completed her graduate degree at St. John's University. She is also an official UK PDA Society and PDA North America Level 1 trained provider in pathological demand avoidance support. And she is the Senior Director of Clinical Operations of Behavioral and Educational Services, as well as Child, Adolescent, and Adult Psychologist at MPG. Dr. Kornblum works closely with families to navigate behavioral challenges associated with ADHD, autism spectrum disorder, and pathological demand avoidance. She approaches treatment from a collaborative perspective and works closely with parents and caregivers, school teams, as well as outside providers to ensure consistency and integrity. And now, without further ado, I'll hand it over to Ariel.
Okay. Hi, everyone. Welcome. I'm sure most of you here know me. If not, it's great to meet you all and have you all here today. So today we're talking about PDA, and many people here, others from the practice and outside the practice, I've spoken with a lot about PDA. And just by way of a little bit of background, about 5 years or so ago, I had a family I was working with come to me and say, our child has this profile of autism. It's called PDA. And I was like, what are you talking about? I've never heard that before. It's not in the DSM. I haven't come across that at all. But, obviously had an open mind and met with that family and another consultant that they had been working with. And that is when I started to learn a lot more about PDA, pursued training in the UK, and just started reading more and meeting with some other individuals here who were treating individuals and their families who met this diagnostic profile. And, along the same lines of the fact that we had been at the time already starting to evolve a lot of our ABA practices, and we were already questioning a lot of what was sort of more old school training versus what we were trying to accomplish today. My education was coming alongside all of that. And it really opened my eyes to just more profiles of autism, what diagnostic criteria can really look like when we are taking PDA into consideration. And from that point on, I started working with more and more families who felt that their child met this diagnostic criteria for PDA. And in the last couple of years, all of a sudden, I have been hearing more and more and more. I get at least an email a day from a family seeking some sort of consult. I hear from professionals all the time, wondering if they can learn a little bit more. In the last year, 18 months, I've started to see PDA come up on neuropsychological reports. So it's really amazing that this community has kept an open mind to PDA and continued to expand what diagnostic criteria and treatment can look like. So I'm really excited to talk with all of you today. This has been something that I am particularly passionate about and I've been working on, for years. So we are going to dive in a little bit more. And today we have three big goals. We're going to talk a little bit more, actually a lot more about PDA, what it is, what are the core characteristics and, diagnostic criteria, so to speak, and how it differs from other conditions, because there is a lot of misdiagnosis in the PDA space. And there's also a lot of just frankly stuff on the internet that exists that it doesn't come from trained clinicians and is really hard to decipher. So we're going to talk a little bit about that as well. And we're going to talk about, how we do a diagnosis of a PDA profile. It clearly looks different than a standard, diagnostic assessment for something like autism or ADHD. And we're going to talk more about, well, okay, diagnosis is important. I think all of us would agree that diagnoses, they have their time, they have their place. They're typically not the end all be all of what the intervention looks like. So, what are the behavioral patterns? What do we see with PDA, and how does it impact different parts of the individual's life experience, right? So, we're going to talk a little bit about school, about therapy, about home, and we're going to talk a lot about evidence-based strategies for supporting these individuals and highlighting that the evidence base here is really important and something that is continuing to evolve. So my hope is that we could do something like this again when we have more and more information about what PDA is and how to effectively work with individuals and families who, meet this diagnostic criteria. And also at the end, I know that many of you here today have reached out to me. We've done lots of consults. I specifically left a good chunk of time for question and answer at the end. I'm probably going to stop throughout and we'll do some, Q&A, and always the chat box in the Q&A is open if you have a question that you'd like to ask. At the end, if you have, a specific question about, something you've come across, or family you've worked with, definitely save that. We're going to dive into more and more the specific examples, because really with this kind of treatment, it is a really collaborative, consultative role that the clinician takes. So I definitely want to make sure that we're talking a lot about that. So, well, what is PDA? PDA stands for Pathological Demand Avoidance. In my opinion and others, it's like a little bit of a harsh name. It sounds, kind of menacing. So there are many individuals in this space, clinicians and parents alike, individuals who, instead of referring to it as pathological demand avoidance, refer to it as pathological drive for autonomy. For the purposes of this webinar, we will be talking about it as PDA. So it comes from the fact that the core feature, and one of the things that we see very clearly, is that demands of all shapes, sizes, different kinds of demands are being avoided by the individual in question. And it is hard to figure out why. Many of us here are trained BCBAs. We analyze behavior for a living. And we have been trained to look for the why. It is what we are best at. And with PDA, it is super hard to figure out the why. It's not as obvious. It's often not objective or measurable or clear to see. And that is where, a couple of hours or maybe an hour and a half from now, we'll be talking a little bit more about the role of ABA in the treatment of PDA. But essentially, it's so different from any behavior that we have otherwise been analyzing as analysts. So the true definition of PDA is a complex behavioral profile on the autism spectrum, characterized by extreme avoidance of everyday demands and significant anxiety around loss of control. A couple of big things to pull out in that. Yes, PDA is super complex. It makes it extraordinarily hard to accurately diagnose. And the average age of diagnosis is far later than what it is for a traditional ASD. PDA is a subtype of particularly level 1 ASD. So really individuals who have a lower support need, who typically utilize spoken language to communicate, average to above average cognitive ability. It is really in that space that we see PDA. The avoidance is extreme. It's not avoidance that is clearly, attached to some sort of, specific anxiety or specific, non-preferred task. Because, and I say this because there are many individuals who have a diagnosis of autism spectrum disorder who also engage in a lot of avoidance. There is a difference between having an avoidant type of ASD versus meeting the criteria for a PDA profile. And we're going to talk a little bit more about that. So what do we see? What is there to look out for? What are some of the things that you should always be keeping in your mind if you are a clinician who might be working with an individual with PDA? So we're looking at resisting, evading, avoiding some of the typical expectations of daily life. Things like hygiene, waking up, getting dressed, going to school, some of the stuff that, if we're thinking about it or a parent is describing it, are things that the individual should be doing, things that either the teachers and the parents and staff believe that this child can do or this individual can do and should be able to do. PDAers do employ social strategies as a means of avoidance. You sometimes see them sort of talk their way out of things, and that's where that level 1 ASD comes into play. PDAers appear to be very socially adept. They are socially motivated, super socially motivated for the most part, and really want to connect with others and are able to on a very surface level, right? In my experience from the families and individuals that I've worked with, it is not hard. In fact, sometimes it's actually pretty easy for the individual to make friends, to meet other people, to sort of form the initial stages of a friendship, which is really interesting because that is something that is typically so difficult for ASD, autistic individuals level 1, 2, or 3. But, a lot of level 1 individuals, with ASD really do struggle to make and form connections. And with PDA, it's definitely different. We do see this social knowledge start to come through, especially, and this is sort of anecdotal from my experience, when it comes to making connections formed over the internet or social media. The deeper things, communication, more complex social interaction, navigating, highs and lows of a friendship and figuring out how to process and work through that is when we start to see the difficulties come out. So, by way of an example, I've had families tell me before, like, there's always some sort of friendship drama or relationship drama going on, even though things seem to have been, perfectly okay. We see a lot of heightened emotions, frequent fluctuations in mood, lots of ups and downs can happen. There's an ease with role play, imagination, fantasy. This is where the social media and living online actually comes into it a little bit more. There is an ease in that world that definitely comes into focus, not so much with the initial referrals, but when we're thinking in hindsight or we're working on treatment plans. And, the same thing, we see that same ease that we get with the social, adaptation, the ability to make friends, but the struggle to keep them. So we have an intense focus sometimes that's directed towards others, whether it's I always need my parent right next to me when I'm watching TV or I'm, scrolling on online. I want, even though that's a very personal and individual activity to be doing, PDAers will often want company when they're doing that. So there's a very intense focus on either the people in their lives, whether those are people who are in person, like family members, or online friends and things like that. And that can be, fictional or real. We sometimes get a lot of focus on just like fictional worlds and things like that as well. Strong need for control. This one is probably going to rise above the rest of them. I've had parents say to me, it doesn't matter what I ask. Every response is an immediate no, or I can't do that. And there is a sense and a strong need for control that feels completely insurmountable no matter what you do, no matter how much prep you do, no matter how big the reward is, or the punishment or the threat of punishment might be. The strong need for control is rooted in anxiety, but that's not always obvious to everyone, as many of us here probably know super well. Anxiety looks different at different ages. For the most part, school age, elementary school age children with anxiety often do exhibit a lot of externalizing behavior versus, older teenagers, adolescents who might be more internalizing about their anxiety. So it's kind of hard to tell like where the strong need for control is coming from. And it's really hard to predict because it can happen on, one day I ask, please brush your teeth and no problem. Go and brush the teeth. And the next day it's like they can't do it at all, right? So there's not a lot of rhyme or reason or predictability. And that is what we hear a lot of when families first hear about PDA, when they first come for an intake. The conventional methods of support, parenting, or teaching. Schools, I mean, for those of you who work with me a lot, you'll hear me say this often. I do feel like we've made wonderful gains, still a lot to be done in terms of inclusivity in the world and understanding of how different people move through the world. Schools tend to be the furthest behind. No matter what we do, most mainstream schools and even many of the, specialized programs really have behavioral expectations for the children who are there, for the students that are there, and they lean on discipline codes and classroom-wide reward systems and punishments in order to make sure that the kids are meeting the expectation for those classrooms. And those things are really difficult for PDAers. The conventional supports that are available in schools, the conventional school or classroom-wide behavior systems are just simply ineffective, no matter how well designed they are or how much integrity there is. Same goes for group-based supports like social skills training or parenting supports, any of the things that are primarily grounded in a behavioral approach are very, very difficult and often ineffective for PDA. That doesn't mean all the time, but certainly there are elements that are not going to be a good fit. So part of the reason and part of one of the biggest things that I want everyone to understand today is this is not simply a question of treatment integrity, right? Research and data tells us that, for example, parent management training or behavioral parent training are evidence-based treatments, including evidence-based for ASD. And if we just, we work with families, we individually tailor the interventions, but we stick with the principles, the guiding principles that are behaviorally grounded, science tells us we should see some success. That is something that I will ask everyone here today to sort of throw out the window for the purposes of the rest of today's workshop. We will talk about it more at the end, but so many of the things, and earlier I mentioned that when PDA first came to me, it was also around the time that we really started working very hard on our neurodiversity affirming practices at MPG. We were overhauling a lot of what we were doing as far as training and supervision. And these things go in line with each other. For those of us who have been trained as BCBAs, we're taught that the science of behavior is the driving force. It's so important. And behavioral principles and the science of behavior is the foundation for many psychological interventions as well. And learning to sort of walk that back and have an open mind is the most important thing if someone comes to you and says, I think my child has PDA, or another clinician comes to you and says, like, I want to work with you on this child who I really feel meets this criteria. So diagnosis. For those of you who don't know, I'm assuming many of you here do know this, PDA is not in the DSM, not in the ICD. It's not a recognized diagnosis. Now, I hope that will change down the line, but for the purposes of today, it's important to talk about the fact that there is no code for it. And that can be really difficult. It shows up in a lot of different ways as being difficult. But it's important to mention and it's important to talk about because it makes it so that a lot of these initial conversations with clinicians and parents can be clouded by the fact that there is not a code for this diagnosis. Now, I've said this probably a million times. I'm sure some of you have said it as well, that diagnostics are important for your insurance purposes. They're not the end all be all. They're not everything. For the sake of PDA, accurately getting to a diagnosis, one that you feel confident in, is actually so important. Yes, we are still treating what we see, and the symptoms are just as important, but having the criteria there and making sure that it is clear that this individual meets the criteria for this profile is so important, because that will travel with them, and it will make sure that anyone that interacts with this individual, whether it's at school or a program or clinicians outside of school, understand that they need to see things through a lens of PDA. And I cannot overstate that, because there are so many interventions, for example, a very traditional form of ABA, that might actually make the situation worse rather than helping at all. So it's not always that some therapy is better than no therapy, and that really rings true for PDA. So we can diagnose, and when I say diagnose, I mean, us as clinicians who are able to make diagnoses, we can talk about the profile as early as the preschool years, around 4 years old. You'll notice that it's a little bit of an older age than a ASD diagnosis, but it's important because we do need to see more of the way that the child moves through different environments, right? And by 4 years old, this child is likely to be in some sort of a school setting, so we can get that information as well. The second bullet, again, PDA not formally recognized, but it is a diagnosable condition in the UK and other countries. The UK is probably like the most, where we see the most amount of like prolific research coming out about PDA. It's been recognized there as a diagnosis for many years. They have specific schools. And if you spend some time listening and reading the stories of adults who have diagnoses of PDA, they tend to be from the UK, because that's where they knew about these diagnoses sooner. I believe that it's also recognized as a diagnosis in Australia or New Zealand, but UK is really the one where we see it primarily. In the States, we have a wonderful organization called PDA North America that is advocating on behalf of these families for inclusion in the DSM here. And they do a lot of incredible work, a lot of free trainings, a lot of parent resources there as well. So the diagnosis of PDA is typically a mixture of a clinical evaluation, specifically a neuropsychological evaluation, and behavioral observations. There is not like a specific diagnostic test. There are, of course, specific diagnostic tests for autism, like the ADAS, the CARS, the GARS. Those do need to be included because, again, PDA is a subtype and a profile of level 1 autism. So we need to be able to accurately diagnose the level 1 ASD, which includes using one of the evidence-based assessment tools, usually an ADAS. So differential diagnosis is extraordinarily difficult with PDA. PDA shares a lot of similarities with other conditions, obviously ASD, but also ODD and ADHD. And many times, particularly if the child is, let's say, 9, 10, 11 years old, and a family comes and they've just been having all kinds of challenges, right? School is a problem. Maybe we see some increased school refusal. There's a lot of behavioral challenges at school, a lot of difficulty moving through rules, routines, things like that at home. Oftentimes when you see a neuropsych from a presentation like that, it might have a mixture of diagnoses on there. In my experience, it's usually ODD and ADHD, if not both of them. And the thing about these diagnoses, obviously they have criteria, and this child might have met the criteria for those diagnoses based on an objective review of their symptoms, but it doesn't help us treat it. So best practices in evidence-based treatment for ADHD, for ODD, are behaviorally grounded treatments. So many times families will come and say, I've tried it all. I've done PCIT. I've done PMT. We did ABA. He's in a behavioral school, and just like nothing's happening, or it's getting worse. In my experience, and I'm pretty sure that the research says this as well, more than half of PDAers really do not have that ASD diagnosis when they are first diagnosed, or even from their second neuropsych. They are often diagnosed with the ASD much later. And that is because they don't really meet the criteria in such an obvious way. We're talking about ASD level 1, but it's really about the social piece. And like I was saying earlier, the social piece is not that surfacey level social piece. It's more of the underlying social piece, maintaining relationships over time, being able to problem solve in any sort of, conflict with a friend. And that just simply doesn't come up. It's not, most of our testing is not very sensitive to that kind of a thing. And if you are an individual that has a clinician here who has treated level 1, level 2 ASD, you'll know that we often recommend things like social skills groups where kids are learning, how to initiate a social interaction, how to make a friend. PDAers, they could do that. They could actually do that fantastically. The other piece of it is that a large number of PDAers are actually girls and women. And we know now, much more than we've known ever before, that females mask at a much higher level than males do, meaning they are able to get through and meet the societal expectations for what their behavior should look like in different environments. So much so that they often do not get the ASD diagnosis because they are so good at the masking. This is a significant issue, not just for PDA, but for ASD diagnostic criteria as well, which is historically based on more of a male presentation and also more of a higher support need presentation. So we really need to have trained clinicians who are able to not just decipher neuropsychs, but know what to look for and what else they need to assess to get to a right diagnostic profile. So we're going to look at parental observations, and that might be structured or unstructured, or probably some mix of both. Also from caregivers, right? We're sending rating scales. We want to understand what caregivers, teachers, parents see on a day-to-day basis, because we are looking to analyze the behavior. Where do these things all connect, and is there a similar undercurrent to all these things? So like we talked about before, anxiety is a huge driving force of PDA. So we're looking to see if all the pieces fit together. So the diagnostic criteria, these are things that are based on the UK societies. So extreme avoidance of demands, just big resistance to expectations, whether they are explicitly stated or sort of just, this is what the expectations are for this environment. Really extreme resistance to any sort of request, expectations. It could be the simplest one down to, all the way to a very advanced request or something that might be difficult. So the avoidance really does not have anything to do with whether or not the individual can do those things. So sometimes with more of a traditional ABA, or parent training, I'll talk with families about whether it's a performance deficit or a skill deficit, right? Is this something that we need to teach, right? Meaning your child or this individual simply does not have the skill. So it's unreasonable to expect that they do something that they do not know how to do. A skill deficit versus a performance deficit. Is this something that we know that this individual knows how to do, and then just for some reason they are not doing it? So it's a little bit different than that, in the sense that some of the tasks are just so simple, and that we're not really talking about skill deficit a lot of the time with a lot of these more simple tasks. So that's the first thing. Extreme avoidance of demands. Just because a family comes and says there's extreme demand avoidance happening doesn't automatically mean PDA at all, but it is one of the things that we look for. The second is the use of social strategies. Charming, distracting, and the big one, negotiating. Lots of really intense negotiation happens with PDAers. And because of their ability, for the most part, to negotiate and to charm and to, again, have those really good, solid, surface level social skills, so many clinicians are like, this can't be autism, right? Like that doesn't make sense. So you really need a very, very trained clinician. Mood variability, big, sudden mood shifts that are not otherwise explained. The only thing that's shifting in the environment is really the demands that are there. And the demands may not always be so obvious. Sometimes the demands are, they are just less clear. And they are under the surface, and there may be demands that are given without actual words or explicit language. And these are things that are, once you get a little bit down the road of looking at and analyzing what's going on in the environment, we can see a little bit more of like, oh, that's a demand, even though I wasn't thinking about that as a demand. Strong need for control. Many families and parents will say from a young age, there was a strong need for control that felt outside what is typical for, you know, a 2-year-old or a 3-year-old, where we do tend to see a lot of control happening there. There's a lot of assertion of independence at those ages, but parents who are saying, no, I have an older child. This really felt like more so than that, or they really stuck out in comparison to same age peers. The way I like to describe PDA a lot is sort of this mashup of level 1 ASD symptoms, predominantly the social stuff, with severe anxiety. And the anxiety might not come across right away, but it should come up in the course of an evaluation. Any sort of interview, structured, unstructured, rating scales should pick up on the anxiety because it is so extreme. Okay, so let's say we're looking at this, right? How do we diagnose PDA? So we have step 1 is our initial assessment, a comprehensive interview. So it depends on the age of the individual, if we're going to, or how comprehensive the interview is. Obviously, all if you're doing psychologist or doing neuropsych, you're going to meet with the individual. Some of the older individuals, and speaking from experience, because I've had this before, who are maybe in their 20s or their 30s, and they have sort of self-diagnosed from something they've seen online, and they're looking for confirmation. So the comprehensive interview with the individual is different, obviously, depending on who the individual is. But the interview needs to happen with the individual, parents, teachers, caregivers, anyone who spends any significant amount of time with this individual needs to sit for a comprehensive interview. And that's because we're looking for the full scope of the behavior. PDA is a diagnosis that it doesn't exist in one environment and not the other. The behavior might look different. We might see different things in school versus home, but the undercurrent of all the challenges really will exist across both environments, if not more than 2 environments. So that is part of what we're looking for. I would say it's probably similar to the fact that, ADHD symptoms, they need to happen in 2 environments in order to be considered for diagnosis, sort of similar to that. We also need a very in-depth behavioral observation, usually occurring over a number of days, looking at different hours of the day, different environments. We are looking to get the full spectrum of what is going on and how this individual reacts to demands in different settings. Then we're doing our full, neuropsych for the most part, unless there's been a neuropsych within the last year or so, looking at all the different cognitive functions, executive functionings, rating scales. We need to be able to rule out and make a differential diagnosis. So like I said earlier, we need to be employing either an ADOS, a GARS, a CARS to make sure that the level 1 ASD is there as well. So we have that first, right? So we must rule out that it's ASD level 2 or 3, or predominantly level 1 ASD with some anxious avoidant behavior, and not really PDA, but just having some avoidance there. ODD is the biggest one. For the most part, what we see is individuals who meet criteria for a PDA profile are often misdiagnosed as ODD. All clinicians have their different feelings about ODD. To me, I feel it's sort of a catch-all, doesn't give us a whole lot of actionable information, and it's really not that great at targeting what's really going on, and it certainly doesn't really speak to the underlying nature of what could be going on. It really talks about mostly the behavior that we see, the observable behavior. PDA and ODD both involve oppositional behavior. And when I say that, I mean sort of like not doing what the individual has been asked to do. but they are very different in terms of what drives the behavior. And this is where that analysis seriously comes into play. We need to figure out the why. It's not a traditional functional behavior assessment. We're not going to find something that is observable and measurable. We need to be open to, utilizing tools that measure anxiety as part of this, but we need to understand what's driving the behavior. Is it predominantly anxiety? Or is it more of defiance of authority, like where ODD and more of the ODD space? We also need to be able to look at the anxiety disorders. So PDA behaviors, they may look very similar to anxiety related avoidance, but it's sort of the mix. Again, this mashup of the anxiety plus the level 1 ASD symptoms, it's so unique that we need to be able to look at the constellation of symptoms and put it together to get to the answer of PDA. So what testing? So we got to look at executive functioning, of course, the anxiety level, social communication, the ADOS, like I said. There are two specific rating scales that are really important to making the differential diagnosis. And there are links here. This will be shared with you after. They're free, super easy to use. And actually, the second one, the CAT-Q, the Camouflaging Autistic Traits Questionnaire, is a fantastic, very simple questionnaire to use if you are assessing, if anyone here is a neuropsychologist or a psychologist who does comprehensive evaluations, using the CAT-Q, if you have particularly a female, and you are maybe thinking that there's ASD level 1 there, this is super helpful. Because in my experience, I've seen many, many, many younger girls and women who actually do meet criteria for level 1 ASD, but it wasn't picked up by any of the traditional ADOS, CARS, GARS, SRS. It's not picked up by that because of the masking. So the CAT-Q gives you a measure of how high of a masker you are. And if you are doing that with someone you are assessing, you will be able to tell, okay, I have to sort of see the other testing results, predominantly the ASD testing results, through the lens of this person being a very high masker. The second is the Extreme Demand Avoidance Questionnaire. This is getting right down to the demand avoidance, and it gives us some standardized data to show that the demand avoidance is more extreme than what we would typically consider to be happening maybe in just a traditional generalized anxiety disorder, or maybe a level 1 ASD with just some anxious behavior involved. At the end of the day, clinician judgment is so, so, so important. Have to use all of the data that you have to see if you can put all the pieces together to feel confident in PDA being the profile here. History is also really important. Going back to those comprehensive interviews, we really need to understand big picture, the history, as well as the details, as well as the context in which the demand avoidance behavior happens. And we're also looking like, how much does this impact? PDA is a spectrum, just like autism is a spectrum. And there are individuals with PDA who are able to, make a lot of traditional societal expectations work for themselves if they have time and energy and space to recharge. And there are other individuals who simply can't, right? They need more accommodation. And that is really important when figuring out the next steps after an evaluation. So we really want to know sort of what's the history here. Something that I will mention at this point is there are things to be wary of. Like I said earlier, PDA, it's not in the DSM. And therefore, there is a lot of not verified information available online. It really only takes a quick Google search to come up with a number of different Facebook groups and Reddit threads where parents are getting together. And this is not to demonize those groups. Those things are fantastic and they provide a lot of wonderful resource. But if a family comes to you and says, my child has PDA, doing more of an in-depth evaluation, if one hasn't been done already, is really a necessary part. The differential diagnosis it's not possible for parents to do it. It is helpful for them to come and say, I think that this might be what's going on. But as a clinician, is really your responsibility to verify that. Going just based on a family saying something might lead you down the wrong path treatment wise. So, this is something that's really, really important to think about. Lots of parents are reading a lot of things and they feel that their child meets criteria for something, but that might not be what it is. So, making sure that there is a very clear diagnosis. And of course, if someone comes and says, I believe PDA is what's going on with my child, they absolutely need to see a neuropsychologist who has PDA training. There needs to be as comprehensive as an assessment as possible so you can get down to what exactly you are treating. PDA is so often misidentified and misdiagnosed, and we don't want to add to that by just taking a parent's word for what their child's diagnosis is. That's not something we would do with any other diagnosis. So clinician judgment is really, really, really important here. Something I'll say, a good question to ask as part of the interview is the family and the individual's previous experience with some of these evidence-based behavioral therapies. More often than not, families would have been down the road of doing some parent training or maybe a group, or maybe they did ABA. You kind of want to know, what was your child's response like, right? How did that work? If a family says right off the bat, like, none of those things ever worked. No reward charts, not the if-thens, like nothing has ever worked. And we've tried it, we've tried this, we've tried that. Like, that's not the end all be all, but that is something to take into consideration, and something that has really opened up my mind when I look back into when I first started. So I had my first job as an RBT when I was still in college. And when I think about the way that I was trained then, lots of compliance training and escape extinction, and I think about PDA, I do think about over the years, the number of, not huge, but like there always were individuals and families I met who there was just no response to the behavioral intervention, and it sometimes made it worse. And, those kiddos have always come to me time and time again where I'm thinking about, well, what was really going on there? What did I miss? Right? We're always trying to get better as clinicians. And it is something important to know. In the past couple of years, I've talked with so many BCBAs specifically who have had some of that same eye-opening analysis. Like, wow, there was just a couple of kids who, no matter what we did or how much we changed the behavior plan, it just nothing ever worked. It was so unpredictable. And all of us at one time or another has said to a parent, well, behavior doesn't occur in a vacuum. And the parent says back, but it feels like it does. It just feels like it comes out of nowhere. And now when I'm thinking about it, and when I look at it, particularly through a PDA lens, the missing piece was looking for the anxiety. So it's really important that if you are going to be either working with a family of a PDA or a PDA themselves, or you are doing psychological testing and diagnosis for an individual who has suspected PDA, that you are really keeping an open mind and utilizing as much as possible some of these assessment tools here. So real brief, how does PDA differ from a traditional ASD? When I say traditional ASD, I'm really talking about level 1 for the sake of this workshop. So again, the main feature is the avoidance of demands for PDA is anxiety driven. With level 1 ASD, we see lots of difficulties in social communication, down to sometimes the basics of social communication. And we sometimes do see the repetitive behavior, the rigidity that's more associated with those repetitive behaviors than primarily with anxiety, although there is a lot of overlap there. So again, differential diagnosis can't be overstated. PDAers will often use social strategies to avoid demands, and ones that can be pretty complex. Really, elaborate distraction and negotiation skills can happen with PDAers. With level 1 ASD, you might see some of that, but not to the same extent. With a social interaction, PDAers, again, they appear super socially fluent, particularly the girls. And now we're in 2025, so much of, teenage social stuff happens by way of social media and online. And we really do see, as particularly the girls, being quite adept at that, the girls who meet criteria for PDA. Social challenges are often more apparent in level 1 ASD. Sort of the tone and intonation that can come up right off the bat, but we really don't see that same ability to really appear socially fluent. Loss of control, perceived loss of control or autonomy, these are the biggest triggers for PDA. Again, that's that pathological drive for autonomy, pervasive drive for autonomy. We're always looking to stay in control. With ASD level 1, we do see some social misunderstandings, the inability to sort of perceive what's happening in a back and forth, a lot of more sensory overload sometimes. With the emotional regulation, demands equal meltdowns, big behavioral challenges. That might happen more from sensory overload in a level 1 ASD. Again, okay, so this is the biggest piece. Treatment approach. PDAs require indirect and flexible strategies. Traditional level 1 ASD is treatment considerations usually are more from a structured place, more predictability, more structure, all these things, they really help with the anxiety that comes along. So just in general, ASD level 1 and anxiety there's a lot of comorbidity there. So many times we will see like extreme rigidity in individuals diagnosed with autism level 1, and there's a lot of anxiety that comes from being asked to be flexible or when something changes in the schedule. That is not PDA. That is a very different kind of anxiety, although it's still anxiety, again, where the differential diagnosis comes up. But structured visual schedules, predictability in the schedule and in the environment are key for those things with ASD level 1 and are actually not key for PDA, particularly the anxiety that comes with PDA. So we're going to talk a little bit more about that in a little bit. So I'm going to go through, actually, I'm going to stop here for a second. Does anyone have any questions, particularly about the diagnosis of PDA? If you do, drop it in the chat. Okay. If you have a question, type it in, but if not, we're going to go to case studies. So these are a few case studies here for the presenting issues, things you might see, come through by way of an intake to you if you're doing an assessment or an initial, just an intake for therapy. So first one is for diagnosis in a teenager, 15 years old, high school student, Emily. So Emily's been struggling academically and socially for years. When we say struggling academically, it's predominantly around refusal to complete homework, despite the fact that there's lots of flexibility with extended deadlines, lots of resistance to just the rules, the routines, the structure, the expectations that come with being a student in school. And to be just to be clear, this is a student who's in a mainstream public or private high school. A lot of what teachers might describe as talking back, not listening, not being able to fulfill very simple requests for behavior or things to do in the classroom, not attending required meetings, again, difficulty turning in the assignments. At home, we're seeing extreme anxiety, frustration when asked to do basically anything, helping with housework, cleaning up, loading the dishwasher, any sort of change in a routine, anything that's outside what Emily expected to do on that day. And what the parents were starting to see was just these big shutdowns, these big meltdowns, running away from situations. If she was not able to maintain control exactly the way that she envisioned the control looking like, then we were seeing, and parents were seeing her just completely shut down and not wanting to work with anyone to take on a task, even if it's something that she wanted to do. So Emily does not have any, previous evaluations, no significant learning differences, things like that would be otherwise getting in the way of the academic performance. But we are starting to see over time this behavior get worse, particularly at home. There is this concept and this idea of restraint collapse, which is something that I, as a clinician and as a parent, I really believe very wholeheartedly in. When people, and particularly we see this a lot with girls, Emily in this case is a girl, being able to mask effectively, and when I say effectively, I mean to basically fool everyone that you are able to, keep up with the expectations of the environment. To be able to do that and essentially keep it together for the whole day really results in an exhaustion and a letting go and a just simply not being able to take on another task in the afternoons and the evenings after school. This is a really big thing and something to look out for as it relates to the interview with families, because we're looking to understand if this is something that increases at specific times or when there's specific academic demands going on, or if it's something that just sort of has always been there. So the diagnostic process. Emily's behaviors, they seem to stem from her desire to avoid tasks. She wasn't not motivated. Like I said earlier, she wanted to do certain things and just really simply couldn't. She expressed feelings of being out of control, feeling overwhelmed, lots of shame after meltdowns and things like that. The teachers noted that she was generally calm, pleasant, just there and doing what she needed to be doing until there was a demand. And what they saw was sort of a 0 to 60 agitation and withdrawal from the task itself. So the psychological assessment, looking at emotional regulation, executive functioning, social behaviors, that part of the assessment highlighted anxiety, high severe, clinically severe anxiety. The family interviewed shows that the behaviors at home similar to those at school. The anxiety and control issues at the core of pretty much everything that was going on. Emily, again, being 15 years old, this is an individual that definitely can be part of the diagnostic profile. The self-report questionnaire looked at, internal emotional experiences, feelings of inadequacy, fear of failure that contribute to the avoidance. As part of this, so social anxiety disorder was considered but ruled out. The avoidance was really linked to demand and authority rather than just being more generalized. ASD, so like more of just a predominantly only ASD diagnosis, but the social communication skills as measured by observation and interview and rating scales were age appropriate. And she did demonstrate some flexibility. Again, PDA is like a spectrum. So she did demonstrate some flexibility when she was in control of the situations, right? So let's say she was working with a group on a project. She was better able to do that than other things because she was able to drive how involved or not involved she was. So she ended up being diagnosed with PDA based on the presence of the extreme demand avoidance, some of the social manipulation. There was a lot of negotiation happening there, and the anxiety-driven behaviors. The need for control was central to the difficulties. So that is really, at the end of the day, what distinguishes the PDA from just a traditional anxiety disorder or from ODD. And they created an intervention plan focused on reducing demand-related anxiety, more control, flexible strategies. We're going to talk a little bit more about that. The second case study, so Emily was 15. This is Sam, 4 years old. So much different. Like I said earlier, we can look at PDA, really looking at PDA, at 4 years old. So this is pretty much like the beginning of the process. So, and I think that actually this is a referral that we get a lot in the practice. It comes up just often in lots of different ways. It's not necessarily for PDA, but we do get a lot of referrals from preschool aged families and programs. That's when a lot of different challenges start to come out. So this is a really good one because it's hard to make the differential diagnosis. So Sam was described by his teachers as being very difficult to manage in the classroom, refusal to engage in activities, playing with toys, following directions for group games, drawing, circle time, things like that. Just his behavior, according to the teachers, was outside what their typical expectations were. Kristen, I see a question here. I'm going to answer this question a little bit later. So Sam's refusal to participate was accompanied by dramatic emotional outbursts, really, really big behavior that felt to the teachers as being totally not what they would have expected. So crying, yelling, hiding, no matter what they asked him to do. So simple, just very simple, typical demands like transitions. We're going from the circle to sit at the table. At home, Sam's parents started to report similar patterns, asking when they asked him to eat, to get dressed, to clean up. There was a lot of distress that they were seeing, and they were reporting a high amount of tantrum behavior at home that was only increasing and was very difficult for them to predict. So the thing that both environments said, home and school, is that if Sam really wanted to do something, he was super motivated. It was a task that he really, really, really liked. He was super engaged, highly communicative, flexible, real. When it was his choice to do something, there were no challenges at all. So where do we go? This referral comes into you. You're thinking, oh, wow, this can be a lot of different things. So we're hearing basically increased externalizing behavior happening at home and at school. And this is a preschool 4-year-old. So first step is let's go see. Let's go see, right? Let's go see what's going on in the classroom. So the initial observation. So he interacted well with peers in unstructured play, right? When he was able to choose what he wanted to do, when he wanted to do it, no problems, but could not tolerate any demands that were placed on him during that time frame. Actively avoiding any requested task as simple as put the crayons away or let's move from, this center to this center. He would pretend not to hear the adults or distract them with unrelated questions if they came over to him and tried to get him to, let's say, put his art supplies away so he could go do something else. He would pepper them with lots of questions that right off the bat wouldn't seem to be a part of this, but seem to appear as a pattern in terms of avoiding the task. So they use the direct observation, parent questionnaires. In this case, parent questionnaires are likely to be like a BASC to start off with, just a broad behavioral questionnaire. And they're looking to assess his response to various demands. So it really looked to be less about defiance. It didn't look like he was attempting to maybe get a rise out of an adult or, to make them annoyed, but really about avoiding something that was stressing him out. Early intervention specialists, they worked with Sam's parents to look at and gather additional information. So again, we're looking at patterns. BCBA psychologists alike, will lean on ABC charts and things, narrative ABC charts, still fantastic to use in this situation. We're looking at what happened before, what the behavior itself looked like, and what happened right after. And that can give us a whole ton of insight into what's going on here. We just need to have an open mind that the function might be anxiety. So ODD, it was considered still young for that, but ruled out because, again, we're really talking about anxiety. He ended up being diagnosed with PDA. There's a clear pattern of avoidance, anxiety-driven behaviors, and the social strategies to avoid tasks were there. They were consistent. Those behaviors were consistent across home and school. He also, like I mentioned earlier, did quite well with unstructured play, and it was mostly more of a parallel play. With the kiddos who are this age, the level one ASD is typically actually diagnosed at a later age. So it's a little harder to see that, but there were some challenges with, sort of teamwork and working together alongside a peer or a friend to, let's say, build something or do some sort of an activity. Something that's so important, again, this case study and the last one, the demand avoidance behaviors are there across the board. It's not like in one environment there's lots of different challenges and in one environment there are none at all. There's no way to have a demand-free world. So if the individual who we're talking about really does meet criteria for PDA, you will see the behavior across the board. It might not look exactly the same, but it will have the same underlying patterns. So because of that, there was the need for the diagnosis to better support him. The plan was focused on reducing the demand, offering choices, offering a greater sense of control. And we're going to talk a little bit more about that as we keep moving on. Okay, so how do symptoms of PDA manifest at home? So big ticket items. Lots of structure, lots of difficulties with daily structure, routines, and expectations. Even though it might be the same routine and the same expectation every single day and not change at all. Most parents who have done any sort of parent training or read a book or taken a course know that kids thrive on routines. As parents are always told, you got to make routines. You got to stick to the routines. You have to have the same routine for bedtime. And that's how our kids get comfortable and they get used to things. It doesn't matter if you've been doing the same routine for 3 years, there's going to be struggles with it. That's a really important data point for parents to keep, to keep a hold of. Those expectations, it doesn't matter. The expectations could be low, they could be super high. There's going to be a challenge with them. Emotional outbursts or big shutdowns, big challenging behavior when demands feel overwhelming to the kid or to the individual. And the avoidance behaviors that can impact family dynamics and social participation. So something that comes up a lot time and time again with PDAers and their families is it's really hard to make plans. If you say on Tuesday that on Saturday you want to go, ice skating with a friend, that really, the fact that it was said on Tuesday and a plan was made, and you even get Wednesday, Thursday, and Friday to talk about the plan and get set up for the plan, it doesn't guarantee that anyone's going to go. And of course, kids, individuals, adults, everyone, diagnosis, no diagnosis, sometimes don't follow through on a plan that they made. But this is something that comes through time and time again, and it really starts to impact family dynamics, particularly when there are other siblings. Avoidance of routines. Again, bedtimes, meals. Personal hygiene is a huge one here. In every family that I have worked with where we have made, worked off a PDA diagnosis, their personal hygiene has been an issue, whether it is toileting, showering, teeth brushing. It can be really difficult, and it is something that comes up. There's no, at least I have not read so many details as to why personal hygiene is a pattern that we see time and time again, but it is really difficult. And individuals, many of them are not receptive, or they're receptive in varying degrees to, things like natural consequences for, let's say, not showering or brushing your teeth. Big emotional responses to perceived pressure. Perceived is the big word here. If you are a parent or a caregiver or a teacher, you might think that the way you are asking something or the demands of the setting which you are in are manageable. They might not be manageable on that day. So that's something we have to stay open to. Huge dependence on caregivers. I talked about this earlier. Many PDAers want to be basically next to a caregiver, no matter what they're doing at all times, even if they're just sitting there watching TV. They want someone next to them to watch TV with them. They want someone next to them while they're scrolling on their phone. That doesn't seem to abate over time. And that's also another really important data point to get when you're doing the first interview. And that really means that we're not going to see a whole ton of independence in lots of different tasks. So examples, big ones. Refusing to get dressed from school. School refusal is enormous with PDA. There is a high degree of comorbidity. Most PDAers, a lot of PDAers are really unable to do the traditional expectations of either a mainstream or a specialized school program, and it ebbs and flows. Lots of distraction, lots of negotiation to delay chores or daily expectations, eating, bedtime, things like that. Totally overwhelmed by transitions, even with all the best countdowns and clocks and warnings and all that kind of stuff. It can still be really difficult, even if it's going from a non-preferred to a preferred activity. That can sometimes be hard as well. That's actually a little bit of an inkling into another area of difference between PDA and like a level 1 autism, or just autism in general, is that, moving from non-preferred to preferred is typically something that is quite easy for, autistic individuals, or really any individual. But with PDAers, it can sometimes be hard. So that's the home. PDA in the home can be really taxing for families. You'll find that by the time a family has sort of found out about PDA, whether it's through, more often than not, they find out about it like online or from a friend. I would say more and more, and I hope that this continues to increase. We're seeing it diagnosed on neuropsychological evaluations, and that is the way they're finding out about it. But by the time they reach diagnostic clarity, for the most part, families are burnt out. They are super overwhelmed. They've often spent like so many resources, their time, their energy, their money on therapies that didn't work. They're constantly in communication with schools. There's always issues. They're just, for the most part, totally exasperated by the whole situation, and they are looking for support. They need a lot of support right off the bat. In the community, we see a lot of avoidance of social situations where things might get a little bit deeper, right? So for example, one-on-one, two-on-one play dates, group activities where they're sort of in a small group, and being asked to do either one thing or a lot of things. Overwhelm in public spaces, something that we haven't talked about a lot yet, but PDAers, much like autistic individuals, tend to have a higher, sensory need. They're usually hypersensitive for the most part, and they can be triggered. Their anxiety can be triggered by sensory input, whether it's too hot, too cold, too crowded, too loud. All of those sorts of things are, things to look out for. Big refusal to participate in structured activities, sports, clubs, things like that usually are, if not hard at the beginning, tend to either ebb and flow in terms of how difficult they are, or over time they get increasingly more difficult. Because of that, the next bullet point, the need for control. Specific choices, dictating group plans. For example, for playing a sport and it's a team practice, wanting to dictate who practices what, who's in what position, what they're doing first, what they're doing second, what they're doing third. PDAers, for the most part, their need for control, it almost appears that they see themselves on the same level as like an adult or a decision maker. I've had parents say to me, like, he or she feels that they have a seat at this table in terms of making a decision, and they have no real acknowledgement of the fact that like they are the child and I'm the parent. And that is something that comes up time and time again, where there is this sort of the need for control is so significant that it comes across as bossy, like very bossy, even though that's not the intention. So very, very, very important. That is not the intention. Many times PDA's behavior is described by teachers, by parents, as willful, that they are just defiant for the sake of being defiant. And that's why we get a lot of those ODD diagnoses. They're super misunderstood. And that happens a lot because adults, caregivers, teachers, they assume, based on their academic ability, their cognitive ability, their communication skills, their surface level communication skills, that they can do all the things that they are refusing to do. And if the anxiety is not front and center, meaning that people know about it, they tend to assume that the behavior is super willful. I've heard from teachers, from many teachers before, this child they're so rude, they're so disrespectful. And over time, if any of you have ever worked in a school, like that can be quite damaging for an individual to sort of get that reputation as being a kid that doesn't listen, or a kid that's just willful, defying authority because they want to. So the deep misunderstanding of PDAers is a huge problem, and it is a real impediment to getting treatment. So examples in the community: participation in family outings, huge one. That's really difficult. Difficulty going into a store, particularly if that store is not one that they're used to, or is louder or brighter, has overhead lights they don't like. Avoiding interactions with unfamiliar people, resistance to joining group games or following schedules for events. These are all things where the theme is, I am not in control. So I think that this is a good place actually to take a little bit of a break before we get into treatment planning. So Madison, if you're here, I think we could stop the recording and then we'll come back at, let's see, what time is it? 3:10. We'll come back at 3:20. If you have any questions in the meantime, definitely drop them in the chat.
Okay, great.
Okay, so we are going to jump in now to treatment planning. What are the best practices? Let's say you already went through the entire diagnostic process. We have clarity. We're ready to move forward, right? What do we do? So, big picture, what are the goals of treatment for PDA? I think this is really important to talk about. We don't talk about it enough, I think, with our big goals for other treatments, but we're looking to enable the individual to navigate daily life with increased autonomy and reduced anxiety. The goal is for this individual to be able to navigate life on their own terms. We want to foster trust, resilience, and positive engagement across various settings because that's really important in just self-realization and autonomy. So these are our big picture goals. How do we get from point A to point B? Obviously, it's going to look different for every single individual. Like I've said a number of times now, PDA is a spectrum, right? So it's going to look different. The first is tailored and flexible interventions. We need to adjust our expectations to suit the individual's unique profile. I really start here because it's the biggest one. Adjusting expectations and orienting around what is reasonable to expect and what we might have to give up on for now, maybe not forever, but for now, is so important. This is really meeting the individual where they're at. We need to use creative, less straight directive methods to encourage participation. So if any of you are familiar with the concepts of indirect and direct commands, we're going to stay away from direct commands basically at all costs. Developing IEPs for school settings that have specific PDA supports embedded into them. So for the most part, not for the most part, actually, lots of individuals who meet criteria for a PDA profile, think back to that first case study, Emily, they don't have IEPs. They haven't needed them in the past. So a lot of the times this initial process actually includes starting the IEP process. The therapeutic supports. So CBT is something that can be indicated for individuals depending on where they're at in terms of their acceptance of the diagnosis and their motivation to just get from where they are now to where they want to be. So motivational interviewing is important as part of the CBT, but when we start off, again, we're talking about individuals from ages 4 and up. So a 4-year-old is not going to go into CBT, of course, but also a 14-year-old might not be a good fit for CBT. The biggest treatment approach to PDA is a collaborative, team-based consultative approach. We are talking about everyone in this individual's life, parents, caregivers, teachers, therapists, whoever might be involved, talking regularly and making accommodations to meet the individual where they're at. This is not something that yes, team meetings are widely applicable throughout lots of different treatment modalities. But with PDA, it is the single most important thing that the team is made up of individuals who are PDA informed with a PDA expert on the team who can help do the quarterbacking, meaning the increased collaboration with the other service providers, teachers, parents. So quarterbacking is going to be the single most important thing. Parents need someone in their corner who understands PDA and can help to train everyone else that their child or the individual might come into contact with. The second biggest one is the parent training. This is not traditional PMT, PCIT, behavioral parent training. It is very flexible and it comes from a relationship-based approach, which is, coming from a behaviorally trained psychologist, BCBA, is something that is new, right? Like it's not that the behavioral stuff has no place at all, but it is a much different approach to parent training. Sensory integration therapy for sensory sensitivities. Occupational therapists are a tremendous part of teams for PDAers. They have so much knowledge to bring to the table when working with these individuals, so they really need to have a very clear seat at the table. Medication management is a huge piece of the puzzle for PDA for most individuals. Obviously, not for everyone, but the medication management piece is for the anxiety. The anxiety treatment with PDA, the anxiety is so, so, so high. It is simply not workable from a therapeutic perspective. There needs to be some sort of medication management to at least bring it down a notch so that therapy can be somewhat impactful. Many times individuals who maybe get diagnosed with PDA a little bit later, they're already receiving med management from a psychiatrist for maybe an ADHD diagnosis or for, a mood disorder. So really having a psychiatrist in the loop who is at least open to learning about PDA or hearing about PDA is really important. In my experience, I have maybe met one psychiatrist who's heard of PDA but doesn't have specific training. So again, the quarterback in the situation is so important because that's the person that's basically running the show. They are facilitating communication, talking to everyone, making sure that we can pivot on a dime to do something different. Treatment approaches need to be altered all the time with PDA. Collaborative problem solving, involving the individual in creating strategies and solutions. I said earlier that individuals with PDA want to feel like they have a seat at the table. We are going to give them a seat at the table. They need to be involved in creating the strategies and the solutions to the challenges. Focus on shared goals and mutual understanding. So often PDAers feel misunderstood. They, for the most part, have been misunderstood and usually misdiagnosed. So it is a really big gesture of moving forward to really focus on that mutual understanding and a shared process. Consistency is key. This isn't just for PDA. Across the board, consistency is pretty much everything. If you worked with me on a treatment team before, I'll always say the devil's in the details. Things fall apart when we are not consistent. Parents, teachers, caregivers, everyone needs to use a similar approach. This is so, so, so important. Monitoring and adjusting the treatment plan. It needs to be continually assessed more often than any behavior plan or treatment plan has ever been assessed before. Sometimes throughout the day, we are making changes based on what we are seeing. The progress needs to be monitored and adjusted. The strategies need to be adjusted in a way that can meet the child where they are at. Again, we are not going to push harder to get either compliance or some sort of behavior we want to see. We are going to walk back our demands as needed. Flexibility. We have to be open, adaptable, open to changing approaches, depending on what's going on with the individual on that day. Something that is super important, and I know I said if you take away one thing earlier, this is the second thing I would really want everyone to take away, that sometimes the best therapy is doing nothing. Part of what we need to do when treating PDA is knowing when to step back. Knowing when to step back and wait and offer opportunities, but wait and show the individual that no matter what, when they are ready to do something or they're ready to work, we will be there for them, is a clinical skill that cannot be overstated. We are clinicians. We're there to do therapy. We're there to make changes, meaningful changes. Sometimes in order to do that, we need to do nothing. And that is a really, really, really big piece of PDA. PDAers on some days are able to do a whole lot. And you can just tell. Like I'll often say with some families I work with and some clinicians, it's not objective. It's just, it could be a vibe. So we have to know this is a day where I feel like I can push a little harder. And there will be other days when you walk into a family's home, if you're doing home-based therapy or they come into the office and this is a day I'm going to walk it back. And sometimes that changes throughout the course of the time that you're there, but it is so important to have that clinical sense. Small successes are everything. We love a little victory. We are going to celebrate progress, no matter how small, to make sure that we are acknowledging all it takes to make a small difference. The last thing is relationships are key. Relationships are pretty much everything with PDA. If you do not have a relationship with the individual that you are seeking to support, you will not be able to offer them anything. They need to feel comfortable and confident in the relationship so that they can, when they are ready to start doing something or to make a change, that they know that they can depend on you to do that. And this is a really tough thing with relationships because it extends not just to therapy, but of course to parent-child relationship and also teachers. And teachers change, they change year to year. Sometimes they change throughout a year. Sometimes service providers change. And in order to really make sure that we're leaning into facilitating those relationships, that is why, again, we need that really strong quarterback on the team who can talk with any new teacher or any new service provider about how important relationships are and the best ways to build them. So, areas to avoid. These are big ones. Traditional behavioral approaches have no place in treatment of PDA. Reward systems, punishment systems, they often increase anxiety and they increase resistance. This is obviously a very blanket statement, and there's nuance. There are some individuals who might do okay with some sort of reward chart. For the most part, these systems are not going to work because it doesn't matter how great the reward is that you dangle in front of the individual. The avoidance of the anxiety is always going to be more motivating for them. And this is a very important driving force of PDA. It may lead to escalation of the demand avoidance behaviors because now they have a secondary anxiety about getting the reward that they really want. And if you really want something but you can't get it, not for lack of trying, that is really, really, really deflating, and it can impact self-esteem very significantly. So traditional behavioral approaches are not that ABA is out the window completely, not that any aspect of parent management training or PCIT is out the window completely. Just a very, very traditional, no room for nuance behavioral approach is not going to be a good fit. The second is forcing compliance. No way. We're giving up on forcing compliance. Direct confrontation or the insistence, that's going to spike the anxiety. It's going to give us big behavioral challenges, and it undermines the trust and emotional safety. This is back to the relationships are key. Relationship will drive everything. Inflexible routines, rigid schedules, they can amplify stress, they can trigger avoidance. If there is no room for choice or control throughout a day, a week, a moment, it's not going to work. This is back to sort of the difference between PDA and a more traditional level 1 ASD diagnosis, where we might lean in a little bit more to predictability and schedule. With PDA, we're not going to do that. We need to allow ongoing flexibility. We need to be able to adapt to what is in front of us, and we need to be able to do that quickly. So that means that we're not going to be like, well, this is what the schedule says. We need to do it next. Overwhelming. An onslaught of tasks or demands, no way, that's going to lead to straight to emotional overload, and it would be unreasonable to expect any sort of movement on getting any of those things done. Pacing is really important. Like I said, vibes are important here. Some days you might be able to do more. Some days you have to do less. You need to, as a clinician, base your pacing and what you are expecting on a day-to-day and sometimes within session basis. So we're going to get into now, okay, so all those things are great, right? Like we need to be more flexible. We need to be more adaptable. We need to meet the individual where they're at. We need to have a lower demand lifestyle, which is something that is big in the PDA space. But how do we do that? If we're a clinician and we're working with a family, how do we structure our sessions? How do we do our parent training? How do we train and supervise clinicians who are working directly with the individual? We're going to start talking more about the details of that now. So this is the PANDA approach. You can very easily find the really cool graphics and more resources on it on the UK PDA website. But it's the framework. It's basically the framework for how we are going to approach treatment to meet the needs of an individual with PDA. And it has all these different components. P is for pick battles, A for anxiety management, N for negotiation, D for disguise and managing demands, and A for adaptation. So picking battles. Picking battles is pretty much, it's a driving force in lots of parent training modalities. Sometimes I'll say to parents, if I'm doing PMT, the question you need to be asking yourself before you deliver a direct command is this the hill that I am ready to die on? And that is a really important question when doing these things too. Strategy is a lot here. It's a big piece of the puzzle. You need to prioritize the essential demands and let go of the non-essential ones. A lower demand lifestyle does not mean a no demand lifestyle. There's no such thing as a no demand lifestyle. There are going to be inherent expectations and demands throughout all different aspects of society. We cannot eliminate all of them, and that would also be irresponsible for our individuals as they grow up. But there are probably far less essential demands than we are thinking of, or that are typically being demanded of the individual on a day-to-day basis. Letting go of the non-essential ones will reduce those confrontations. And the more that we can reduce confrontations, the better. So what do we need to focus on? Safety. Obviously, safety is a huge thing. That's not therapeutic, really. That's just making sure that we are safe, right? It is a demand that you hold my hand when we cross the street. That's immovable. We're not changing that. You need to put your seatbelt on when you're in the car. These are absolutely essential demands. You cannot let go of them. It's not possible. Allow flexibility in less critical areas. This will ebb and flow. Sometimes, we're in a space that we can push maybe a little bit more to increase the demand level. And sometimes maybe we're in burnout or we're approaching burnout and we need to allow more flexibility, right? Like maybe you don't need to shower, you could shower every few days instead of once a day. Encourage autonomy. If the individual is involved in making the decisions on what sort of essential demands need to be prioritized, you will get more buy-in and more success. So again, allowing the individual a seat at the table. Anxiety management, huge. We talked about medication management as being a very critical part of this. It is a very, very, very important part. But the anxiety is the driving force, and it needs to be managed in order to make any progress here or to allow the individual to achieve what they want to achieve. So we need to implement techniques to help the individual manage anxiety. Low demand environment is one of those, not having to contend with every time I turn around, there's a demand, whether spoken or unspoken, is a big deal. Flexibility in the routines, right? There's routines there, but the individual knows that there's flexibility. Calming activities, sensory tools, these things are really important. If you have an individual who's older or more amenable to CBT, like we talked about earlier, there will be, or ACT, there will be strategies for for coping skills that can be worked on in session, practice outside of session, different tools for that. So we want to make sure in the anxiety management, we are constantly assessing what's working and what's not working and what we can add, because it is so important that get at least somewhat under control in order to have any sort of movement here. Oh, wrong way. The next one is negotiation. So in a traditional parent training, for example, you're giving a direct command, like as a clinician, you wouldn't tell your parent that you're working with to negotiate with their child. With PDA, we will negotiate. So another one of these sort of ingrained clinical things that we need to open our eyes to and be a little bit more flexible. The negotiation can be collaborative. It should be calmer. It shouldn't be heated negotiation. But it's looking at finding a mutually agreeable solution, right? Here's where I am. Here's where you are. Can we meet somewhere in the middle? More often than not, families can negotiate more on certain things than they are already. So examples of how to do this well: open-ended questions, really, really good, puts the ball in the individual's court. Choices, forced choices are fantastic. Forced choices are a great parenting strategy across the board in lots of different modalities. And basically, when you have developed a number of choices as a parent that you would be okay with, but you allow the child or the individual to choose which one they do first or which one they do at all, meaning you would be fine with any of the choices. This is a big one. Parents, caregivers, teachers, you have to be prepared to compromise and find middle ground. If you're engaging in a performative negotiation with the individual, but you're not exactly prepared to compromise, you chose the wrong thing to negotiate about. So much of the treatment for PDA and the treatment planning for PDA is about managing expectations. And parents, caregivers, teachers, everyone needs to be very real with themselves about what they can and cannot manage and where their limits are. So we're not going to just say, okay, well, I'm going to negotiate everything if you don't actually intend to negotiate everything. That would sort of negate the whole purpose of doing it in the first place. Disguise and managing demand. This is a favorite of mine. It's a great strategy. Presenting the same kind of demand, but in a less direct manner to reduce the perceived pressure. It doesn't feel as demanding or as pressurized. So, incorporating the demand into a game or a story, right? Or using indirect language, like, let's see how we can like maybe we'll beat our record for how fast we can take a shower, something silly like that. Challenges like as part of imaginative play, trying to maybe push the envelope on some sort of an exposure or something that might make them anxious. Humor is fantastic in the PDA world. Making light of a situation is that can otherwise feel super serious is so wonderful and can really get a lot of traction in terms of getting the necessary demands completed. Because again, low demand is not no demand. So there will always be a small number of things that need to be asked of an individual, usually on a daily basis. And those are things that they might not want to do, or there might be a lot of difficulty in getting those things done, but they're not movable. So we will come to this point where a family will say, or an individual will say, I have lowered the demands as much as humanly possible. Like I can't possibly lower them any more. That obviously warrants a very frank discussion about whether or not that's truly the case. But if it is the case, then where do we go from here? How can we take that small subset of demands that needs to get completed and make it so that we get more success with getting those things done? Adaptation, continuously adjusting the approach. This is going to happen all day, every day. Again, this is really why you need someone on the team who's able to adapt very quickly and who is able to communicate that adaptation to every member of the team. We need to be observant and see, what is going on like on this day. What's this feeling like? What does, does this physical feeling, or if they're feeling maybe a little bit sick, how does that impact everything else? More communication is always better amongst team members so everyone can be prepared. We always have to stay flexible in the expectations. If tonight I said, oh, I wonder if we could try something new tonight where we, brush our teeth before we take a bath or something like that. And that works, let's say on Tuesday. But on Wednesday, I can't expect the same thing to work. It's not reasonable to expect that we will get the same response by using the same strategy on a day-to-day basis. We might, but we need to be prepared to adapt and to change. We want to have feedback. If you have an individual that you're working with who is like motivated and involved in their own treatment, okay, how's it going? What do you think? Is this helpful for you? Is it not helpful for you? As a clinician, we need to get the feedback from every single stakeholder. That's the individual, parents, families, caregivers, teachers, everyone. We need to be able to pivot quickly. Anyone can learn and read a manual on how to do or how to adapt cognitive behavioral therapy or run an ABA trial. Most people can read books and maybe learn how to do that. Learning how to pivot and knowing when to pivot and being able to be flexible and creative in that approach is something that is much harder to learn. It takes time, it takes practice, and it is the most important thing when learning to treat PDA. Because not being able to pivot and leaning more into a strategy or a demand that is not helping is going to make things worse before they get better. So the PANDA approach is a guiding force for parent training, for individual therapy. It's sort of these like top level, very high level principles that every plan that gets put into place needs to be following. And I like to, when I'm working with families, send them the infographic of it. I have it up like on my desktop all the time. It's a great reminder of what it is, how we need to structure our interventions. I'm going to go through a couple of other really great manualized treatments that have a really good place in the treatment of PDA. So CPS, collaborative problem solving, Ross Green is a really fantastic approach to, you know, trying to manage some challenging behavior to get some traction. And it has a couple of key principles. The first one is the assumption that kids do well if they can. That's it. There's not a willful defiance here. Back to this sort of differential diagnosis. If we give them the tools, they should be able to do it. The second is we are focusing on collaboration, not punishment. We're focused on understanding what's really going on so that we can support the child in getting from point A to point B, rather than, putting some sort of reward or punishment system on top of it. So why CPS? It's the evidence is extraordinarily strong for it. If you haven't already, I would recommend Ross Green's book called The Explosive Child. It's really a great book, and also great for parents to read if you're looking for something to recommend to parents. CPS, it is evidence-based in reducing power struggles and anxiety. It builds those problem-solving skills and communication skills, and it strengthens relationships. All key things that we want to hit when we are doing treatment for PDA. So what's the process for CPS? It's really a very simple process, and it's one that can happen again and again and again. The first step is, empathy and validating the individual's experience. I notice that this is really hard for you. Like, what's going on? Get information. For a PDAer who wants to feel validated, understood, and like they have a seat at the table, this is fantastic. This is an adult coming to them and not saying, you need to do your homework in the next 10 minutes. Like, this is so easy. Why can't you just do it fast? Instead, it's, well, what's going on? You talk to me about it. Tell me about it. And this obviously needs to come from a very genuine place so that the kiddo's not like, you don't really care about that. Okay, so what's defining the problem? Now, as the adult or the caregiver, the parent or the teacher in this situation, you get to share your perspective. You are a student in my class, and it's important that you finish the work so you can learn. Okay, so this is hard for you. This is what you need to do. Let's brainstorm some solutions collaboratively. How about we try this? 10 minutes of work, 20 minutes of work, then we do a break. What do you think? What do you think? Right? So it's very much a collaborative process between the caregiver, the adult, the parent, the teacher, and the child to find to something that is mutually agreeable. And that means as the teacher or as the parent, you're okay with it, and the child's also okay with it, and everyone has buy-in, right? And it's sort of a very feel-good collaborative process that helps everyone work on their problem-solving skills, the parent and the adult included. And from there, what happens is we go and we try it, right? How did it work? Tonight we tried, instead of sitting down and doing the whole hour of homework, we did 20 minutes, and then we took a break, and you and I, played together for 10 minutes, and then you went back to 20 minutes. How did that work for you? And with PDA, this is something that we can do again and again and again, right? And we might need to revisit it, the same thing again and again and again. But it is really good framework for trying to work it out while also allowing that perceived control to really, really play heavily for the individual. This is the question that Kristen asked before. So if anyone's familiar with Hanley, he has My Way ABA. It's a more compassionate approach to applied behavior analysis. If you, jeez, sorry. If you are not familiar with Hanley's work, I would highly, highly, highly recommend checking it out. He is such an innovator, and what he talks about makes so much sense, and it is a really wonderful driving force for how to do therapy. He does have very specific behavioral approaches and different kinds of like manualized treatments, but the overarching idea is really what I want to focus on here. So the focus of My Way ABA is on enhancing quality of life, dignity for the individual, and their autonomy. It is really designed for individuals who are complex, like PDAers, who have lots of behavioral challenges. They may have trauma histories, and they have anxiety. So we're talking about it being person-centered intervention. We're really talking about like how can we work together to enhance your autonomy so that you can move through life with dignity and you have the quality of life that you want. These are incredible driving forces, ones that we should always aim for no matter what therapy we're doing. But his framework, so to speak, is really highlighting these things. So what are the key principles? Again, sort of like with the CPS model, assume good intentions. We are seeking to understand rather than to control. This is actually the same exact guiding principle, which is why I bring it up here. All behavior is communication. This is something that we're all taught pretty early on, but it's something that Warren's talking about again, which is if we see some sort of a challenging behavior, that is an individual trying to tell us something. It is our job as a clinician to figure out what that is. We are prioritizing safety and we are prioritizing trust. So again, relationships are key. So key in this approach. And we are having a lower demand environment. Low demand, not no demand. Collaborative goal setting, working with individuals and their families to set goals that are meaningful, things that do enhance dignity, that enhance quality of life, and that lead to a greater autonomy. And we are respecting the individual. They have a seat at this table, and their needs and their wants and what they want to work on is respected above anything else. Such important guiding principles, something that I really like. One of the first things I think the first clip I ever saw of Hanley was him talking about the fact that when you are engaged in this kind of therapy, his recommendation is to leave the door open. The child should want to stay with you in the therapeutic environment because they want to be there, not because the door is closed and they can't leave. These are things that are I'll speak for myself, for someone who was first trained in ABA so many years ago, are just so incredible to see that the field is really moving towards the inclusion of these approaches. So what are we doing? Core strategies. First one is SBT. That's what Kristen asked about before, skill-based treatment. So Kristen's question was, does the SBT have a place in treatment for PDA? The answer is here. So yes, it does. Alternative skills to replace challenging behaviors. Again, like there are certain limits, right? If the behavior is super physically aggressive, no one is suggesting that we just sort of let that happen, right? We can still teach alternative skills that replace those behaviors that meet the same need. So communication, emotional regulation, these are big pieces of what we're trying to teach. Open-ended interviews. This is how we're figuring out what the triggers are, what's going on here, what to expect. We need to use those insights to craft very, very personalized interventions. So the open-ended interviews are happening all the time, not just at the point of diagnosis. And the interventions are flexible. The strategies are designed to meet those individual needs, their preference, the individual's preferences, the context for which in which the approach is taking place. And again, the constant adjusting of plans based on continuous feedback. So the thing that I really, really, really like about CPS and also about Hanley's approach is they are wonderful fits for PDA. And they both do have some behavior grounding in behavioral science. So it is really important to note that, again, like I said earlier, it's not that all things behavioral are a no-go for PDA. It's just that we need to be very specific in the way that we are employing the scientific behavioral approach. Which brings me to a note about ABA and PDA. If you ever get a family or a parent of a suspected PDA, one of the first things, more often than not, than they usually say is that my child can't have ABA. ABA is going to be traumatic. ABA is not a good fit for PDA. Okay, so it's not. To be very clear, traditional ABA and PDA do not go together. If you are trained in mostly discrete trial instruction with a focus on compliance and escape extinction, which I will be quite clear, is not acceptable to only be trained in that in 2025, although we still have providers who are leaning into those kinds of therapies. We should not be doing them at all. Here at MPG, we do not do those things at all. But if those are the things that are happening in the course of an ABA session, then they are not compatible at all with PDA. because it will make the anxiety worse. It will lead to more anxiety-driven resistance. But there is a special time and a place for the use of ABA with PDA. And for the most part, I do recommend that families who are in need of wraparound care, of very intensive treatment and support in their homes and in their schools, do employ working with either behavior interventionists or BCBAs, sometimes behavior technicians as well. So how can we use it effectively, right? There are certain aspects of ABA, and I will talk, when I say ABA, I'm talking about, more of the ABA that we're practicing now, trauma-informed, neurodiversity-informing, more play-based approach to therapy. First of all, we have the focus on relationship building. That is it throughout our approach to ABA here at MPG, and it should be throughout other places as well. With PDA, we lean in much, much more to that relationship. It is a driving force, and sometimes we will spend whole sessions just doing relationship building. It happens a lot. Part of relationship building with PDA is knowing when to take a step back. I have consulted and worked with many, many ABA teams who are treating individuals with PDA. And one of the things that we come back to all the time is that in order to build your relationship sometimes, and also in order to preserve your relationship with your client, you need to sometimes just sit and wait for them to be ready. And that might look like just sitting outside their room for an hour and a half and they're with you for 30 minutes of session. That might look like sitting out there for 2 hours and they're not with you for any part of the session. If parents are understanding that that might happen and clinicians are understanding that that is okay and it's actually helpful, then we do have a good starting off point. Prioritizing autonomy and flexibility. ABA approaches can certainly do these things. We can and we should be including always the individual as a stakeholder in their own goal setting as much as possible. And that can include goals that are focused on autonomy. Reframing demands, playful, non-demanding language, using indirect language as much as possible. There's no rule that you need to deliver X number of demands for every ABA session that you do. ACT, acceptance and commitment therapy, is well within the scope for a BCBA, and we can teach coping and regulation skills to individuals who want to learn those things, right? If that's part of what they want to work on and part of their goals for themselves, then we can certainly do that. And as much as possible, we want to be making sure that we at least start to work on those things throughout therapy. Gradual exposure to demands, we could certainly do that. We can use collaborative problem solving is certainly a strategy I talked about earlier that any therapist can employ. Avoiding power struggles, right? Again, we're not doing escape extinction or compliance training or things like that. We can avoid power struggles. You might get less data points, a lot less data points. But ABA is uniquely suited in the way that insurance companies sort of conceptualize and pay for the service, where the families of individuals with PDA who are simply struggling so much. They have children who are unable to go to school for any significant amount of time, or some days they can and some days they can't. For those families to have a full-time or almost full-time wraparound service that they can utilize is so valuable. So we need to, part of why I bring this up is to shift the conversation that there are ways in which ABA and PDA can go together. And there are ways in which that can be highly impactful for an individual and for their family. And the last thing is monitoring and adjusting interventions regularly. Sometimes that means you thought that you could work on a specific skill in a specific way during a session and it's not going the way you intended. Walk it back. We don't need to do that. Again, we're not going for compliance. We're just simply saying we're going to pivot to doing something else. So this is a really important factor. Most parents who Google PDA, who read anything about PDA, are immediately sort of bombarded with information about how damaging ABA can be. And it does not need to be like that at all. it's hard to find practitioners who will make all of these things work. It's hard, but it's not impossible. And it doesn't mean that ABA is a totally inappropriate therapy for inclusion in a treatment plan here. So what about in school? I just said a little something about how school can be really difficult. The kids can engage in a lot of school refusal behavior, go some days, not other days. Again, PDA is a spectrum. We might see varying degrees of challenge in school settings, but what might we see? Either the reluctance to go at all, or once they're there, the refusal to participate in some or all the activities. Use of distractions, negotiations, withdrawal to avoid demands, academic demands, non-academic demands, whatever it is. Again, we might see that social fluency, but then we might start to see lots of issues, maybe around unstructured time, lunch, recess, like what's going on there? There seems to be a lot of social challenges coming up. Again, I mentioned here that girls with PDA profiles typically present more socially adept. They're often higher maskers than their male counterparts. And they have a lot of ongoing issues with maintaining and deepening their relationships. So what are common things that lead to challenges in schools? Rigid schedules, inflexible expectations. Like I said earlier, schools are tough in that way. They have a lot of rigidity for the most part. Even the schools that are super specialized can be very rigid. Authority figures are pervasive in school environments, and PDAers do not really enjoy being around authority figures. So that stuff is a little bit more immovable in a school space. There's a lot of social pressure. As kids get older, there's more and more group work. That's really tough. And then there's sudden changes. There's sudden transitions. There are things that maybe the individual wasn't prepared for, and the environment is not going to prepare them for it. And this can impact learning quite significantly. Lots of loss of academic instruction, difficulty with group projects or any cooperative activity. And then, sometimes we see these more emotional outbursts that can disrupt engagement and focus and can impact other kids in the class or other students in the class. And we might see, ebbs and flows in terms of school refusal. We might see some days are okay, some days are not okay. Sometimes mornings are okay, afternoons are more difficult, all the way from sort of it being inconsistent, all the way through complete school refusal, which often is accompanied by full PDA burnout, meaning the demands have just crossed a level where now the individual needs to basically completely step back from all their day-to-day demands, responsibilities, so that they can recharge. So IEP recommendations. This is a really important one. Schools, for the most part, not super set up to accommodate students with PDA. So it's really tough to get good IEP recommendations in there, but these are some good ones that can go in there. So these would all go for the most part under like management needs if you're familiar with an IEP. So that's sort of after the present levels of performance, there's just a text box for management needs, and you can list as many things that would be helpful for teachers and other school staff to know. So flexible approaches, utilizing that indirect language rather than focus on direct demand heavy language, offer choices as much as possible, avoiding confrontation, particularly when it's in the classroom and there are other students around. A focus on emotional safety, trust, relationships. School counseling is often a good service for PDAers to have if the school counselor is someone that they can build a really positive relationship with. I often find that it's really nice for the student to have a very safe person and also a physically safe and quiet space within the school building, even if they have a great outside therapist. Utilization of positive reinforcement, celebrating small successes, that can be really helpful. Adjusting expectations, so breaking down of tasks, dividing assignments, allowing extra time, things like, more flexible schedules for returning homework or larger projects that can be negotiated on a case-by-case basis, breaks, as much as possible, including project-based learning. Project-based learning is huge for PDAers. If they are interested in something and motivated to learn about something, and you are a great teacher who can incorporate their interest into teaching the curriculum, that's going to be fantastic. I've had kiddos that I've worked with who have, for example, like I had a client who was super interested in planets and in space, and his teacher, he was in a one-to-one school at the time, allowed basically an entire unit on that, but was able to incorporate different things from the math curriculum and the science curriculum to make it as educational as possible, culminating in that student creating their own PowerPoint and presenting to other kids. So there's lots of great ways to employ project-based learning if you have a school team that is amenable to doing that. Because again, it's really hard to do that in a larger or mainstream school, a school environment. Something I want to say quickly about positive reinforcement is it can be used with PDA. I have it here to celebrate small successes. We talked a little bit about before, like behavior charts and things like that are going to be a no-go because there's too much time to think about doing the thing that gets you the reward. So I'll often have families sort of do a sneak reward. So let's say their child does something that they know is hard for them to do. They can say, let's doctor's appointment. And they go and they do it successfully. On the way out of the doctor's appointment, I'll often have parents say, like, hey, like, that was so awesome. I know that's not so easy for you. Would you like to go get, ice cream or go to the toy store, depending on the age of the kid? So it's sort of like a lower key positive reinforcement, but it still shows that acknowledgement. And that can be quite a good fit for some individuals with PDA, not all of them. So those were IEP strategies. What about bigger, larger classroom strategies? Again, big thing to reduce anxiety, breaks, either a calm corner, safe space for self-regulation. I'll often push schools. I did it just this morning, like trying to allow the child, free reign within a specific part of the school building if they're of an age and they're safe enough to do so. Visual schedules are good, but there's, again, needs to be some flexibility throughout. Like the student needs to know that, yes, the visual schedule is there, but it's not, I don't absolutely need to do every single thing on that schedule. Preparation for transitions, really good. Incorporating their passions, right, for project-based learning, using their interests as a bridge to academic content. Lots of individuals, PDAers, when we talk about level 1 ASD, there's a lot of like focused interest sometimes. So I've had some teachers who really successfully work with a student to pull out what is that student's like big passion interest and make it so that that student can create academic content around it. They can teach other kids, they can present to the class. Again, it's case by case. It depends on the kid. Open-ended tasks are always going to be better. I've had suggested to different teachers with varying degrees of success that there's an option to do projects in a group or do them individually for PDAers because sometimes the group can just feel too demanding. If that can't happen, assigning a peer that the teacher knows is super supportive, or the teacher providing some additional support to the group as well. But minimizing the pressure of the larger group activities. So a really easy one to do is like if lunch and recess are overwhelming for one reason or another, offering alternatives, coming to eat in the classroom or, doing some task in the library or something like that as a choice. So again, it's not a demand that you don't go to lunch and you eat lunch in the classroom, but rather a choice. Where would you like to do this today? So collaboration and communication, they're key for treatment teams, and that includes the school, right? So regular feedback from the student, how's it going? What do you think about this? Have them design strategies or help to design strategies that work for them. Had a lot of success, including students and individuals in different parts of their own planning. Even having of a certain age, if you have a client who is interested in learning more about PDA or learning more about autism, there are really great books that are like, there's one I can send later. It's sort of like from the diary of a teenage PDA girl, and it's talking about her experience. So that's really can be really empowering and something that we should really be using. regular updates with families, consistent communication. If you're the quarterback in the situation, it is your responsibility to develop the modality for the communication. Is it going to be a daily email? Is there a weekly report? Is there a weekly team meeting? Establishing that from the get-go is super important. Logistics are really critical in the treatment of PDA because it does require so much collaboration. We want to highlight positives. We love, again, a little victory across the board. Specialists are really important. Sometimes ABA therapists get sort of a rap for not working well with others. In the case of PDA, it is so critical that we do. So engaging the OTs, the speech therapists, having someone on the team that's PDA trained is super important. And then provide training. If you're the consultant or the quarterback on the team who's the one who knows the most about PDA, getting access to other individuals to get that same level of training is really important. I've found sort of in my travels over the last couple of years that there are more clinicians than we think that want to learn more. And sometimes they just need like here's a great book or here's a link for them to get more informed. And I really feel that that's how this, interest and inclusivity of PDA as a profile has really grown so significantly because of that. So there are many PDAers who cannot meet the expectations and the demands of full-time school, whether it is a mainstream school, a specialized school, a flexible school. Schools have to abide by certain dictates, certain rules, and honestly laws. And that can really sometimes not work in the favor of a PDAer who requires a degree of flexibility that a school cannot provide. The good thing about 2025 is we have lots of options for school now. There are many, many, many ways to get an education. And also there are many, many ways to make a living that are more, there's more autonomy, there's more time planning that happens on the individual's part. So it's really about finding the right opportunities. So homeschooling can be really good with a personalized curriculum, flexible schedules, low pressure, and low demands, reducing that anxiety. Unschooling is a term that is super big on a lot of the PDA listservs and the parent groups, and is particularly shown and as an option for individuals who are in burnout, meaning that they are just cannot do anything, right? Like they can't meet their daily living needs. They're in complete school refusal. There's just like any demand is really, really difficult. And there's varying information out there. In my experience, PDA burnout, like if it's true burnout, can really last a number of months. There are clinicians who say that burnout can last, a year. And in that time, we need to unschool, which is basically not homeschooling. It's just learner-driven approach. There's no formal curriculum, and it's just waiting for the individual to want to learn something. It's mostly focused on personal interests, all based on if they're intrinsically motivated to learn something, then there are the parents for the most part, but other adults might be available there to, work with the individual if they have expressed interest in learning something. Specialty schools. There are schools that are tailored for a neurodivergent learners, specifically those who meet a PDA profile. In New York City, there's one downtown, not just for PDA, but for a number of different neurodivergent diagnoses, also on Long Island. These schools emphasize the emotional well-being, relationships, project-based and personalized learning, and sensory accommodations. They are usually one-to-one schools so that they have that freedom to really individually tailor the work. Online learning, virtual learning. I have worked with a couple of families who have engaged in this process with the support of home-based ABA teams, which allows the individual to learn in their preferred home environment. And then also choosing online programs that are not like synchronous over Zoom, but rather are self-paced. And the timing of the lesson is totally on the individual themselves, so they can take as little time or as much time as they want to do something. Part-time schooling or flexible schooling. There are some schools that are okay with that. You come some days, don't come other days, and we'll sort of orient to that. This one is harder, I think. Depends on the school. They really have to be open to it. It's not impossible, but it's pretty difficult. And the last one, and this really speaks to individuals who are going to maybe go to a residential program because the behavior is just simply not manageable and the family dynamics are so severely impacted at home. Nature-based, project-based experiential learning with being hands-on in a low demand, low pressure environment where you are occupied with physically doing things is a really great option for PDAers. There are a number of schools like that throughout the country that really are focused on experiential learning, and that has been shown to be super positive for this population. So ethical considerations when working with PDAers. So respecting the individual's autonomy is so important. Like I said earlier, many times PDAers will have moved through their lives with many of the adults thinking that their behavior is super willful and defiant. And that can really be minimizing in lots of different ways. So we really need to respect their autonomy and avoid being overly directive, anything coercive, punishment, all of that has no place in this treatment. We are prioritizing quality of life and we are looking long term. What is going to set this individual up for success long term with their quality of life, with dignity, with autonomy, and their emotional well being? We are prioritizing all those things over in the moment compliance with tasks. Their approach is collaboration. That is the treatment. So it's not just one modality or another modality or one kind of therapist or another kind of therapist. The true only way forward is to have real collaboration amongst every stakeholder, all the therapists, family, teachers, the individual themselves. If we don't have that, it's the intervention is not going to be successful and it will really fall apart. Again, the devil's always in the details. If you don't have alignment across the board, or let's say you have a psychiatrist who's been with the family a long time and they're not so sure about PDA. It's not in the DSM. Like that kind of stuff can really, really, really taint the therapy moving forward and the treatment planning. So we're going to go through some case studies of treatment. So first we have Sophie, 5-year-old girl with PDA. Of note, she has a younger brother. Sophie, according to her family, has always been highly sensitive to demands, can be easily overwhelmed by even the simplest of tasks. Lots of episodes of school refusal, a very small social circle, and is not able to tolerate any sort of big group setting. So what do we see, right? Sophie, the family comes for an intake. What are we hearing? Sophie is refusing to participate in group activities or circle time. She hides under tables or behind furniture. At home, refusing to follow basic instructions, eating meals, getting dressed, going to bed, hygiene stuff. Avoiding eye contact, and will not engage in any form of structured play or tasks. The eye contact thing is in here not because eye contact is so important, but it's sort of a one of the strategies used to avoid some demands. There's a high level of family stress due to everything going on. Family can't make any plans. Their plans often fall through on the weekends because Sophie refuses to go. When family visits or a meal is different than what she expected it to be or what she wanted it to be in that exact moment, there are big emotional outbursts. This is really, really difficult, particularly for the parents to manage, and the parents are truly approaching burnout. So, what are our goals? Increasing Sophie's tolerance to new situations, establishing a routine she feels comfortable with, developing some coping strategies, and supporting family members in responding to and setting Sophie up for success. So, a little bit of a question to the chat really quickly. If anyone can write in, like, what might you add to this? What might be part of your treatment plan that I haven't mentioned here for Sophie and her family? We'll do like a minute for that. Does anyone want to unmute and talk a little bit about what their treatment plan might be?
If you do want to mute, you can raise your hand or put it in the chat and we can allow you to open your microphone up.
Okay. Guess not. We'll roll through the next one. So the
Did
second one.
have one person, Lakin said, would there be ways to gather Sophie's input?
Sorry, I missed it. What be a way to what?
Gather Sophie's input.
Yes. So Sophie's 5, right? So getting her input is going to be probably through some sort of play-based intake when you're like sort of low demand, just seeing if you can chat with her a little bit and see if she talks a little bit about her own challenges here. Once you come up with things like what you're going to target, you could certainly employ some of the strategies we talked about earlier via CPS or My Way to get Sophie's buy-in for a specific kind of plan. So our second case study is for Chloe. Is a 14-year-old adolescent girl diagnosed with PDA. Chloe struggles with social interactions, authority figures predominantly at school, super intelligent, and is known for using her wit to sort of get out of certain tasks that she's feeling super anxious about. And there's a pattern of school avoidance here. So not full-blown school refusal, but school avoidance. School absences here and there for not feeling well, pretending to be too tired to attend, avoiding homework and assignments, saying she's too busy or she doesn't feel like it. Lots of strained relationships with peers, friends, but like if anything, a little conflict comes up, she tends to withdraw or become critical. Friends might describe her as a little bit bossy. Lots of power struggles with her parents, using sarcasm or changing the subject to remove herself from demands, often overwhelmed. So there's often times where she just has this big emotional overwhelm when faced with a lot of pressure, expectations. Again, she's 14, so she's in high school. So there are some increased expectations there. So what are we going to do here? Improving coping skills, right? Chloe is 14. It should be an overarching treatment goal, at least at some point, to get Chloe into her own treatment with a therapist that she can trust to start to work on those things, either via CBT or ACT. Increase participation in school by working on those relationships with peers and teachers. Developing the communication strategies so Chloe can self-advocate for herself when something is really hard or her anxiety is too high. And then also here you see encouraging Chloe to set personal goals and working with the team to achieve them. I think just for time's sake, we'll keep going. So conclusions and key takeaways. So if you made it this far, great. I'm so happy you're still here. Treatment of PDA requires a flexible, individualized approach. Our goals are to reduce anxiety and build trust. Relationships are so key. There are specific modalities and adaptations for therapies that are applicable, things like collaborative problem solving, the PANDA approach, Hanley's My Way. But you don't need to just choose one specific modality. You can certainly employ lots of these as long as they follow that overarching approach. Strategies, any strategy you choose, should prioritize collaboration with the child, offer as much control as possible, and minimizing demand. So again, low demand, not no demand. Consistency across home and school and any other environment in which this individual lives in is really critical for success. And the challenges associated with PDA ebb and flow. Sometimes, particularly if there's a moment of burnout or months of burnout, that is extraordinarily difficult, right? It's something that really dominates conversation and day to day. And sometimes like maybe we've got a good thing going. We have a good rhythm, a great team, good relationships, and an individual as they get older who's, accepting and working more and more to self-advocate and manage their own anxieties. And maybe they have a really good medication management at the moment. And PDA is not always going to be the defining thing of who they are. Sometimes things are okay. So it does ebb and flow. So we finally got to the Q&A part. I specifically wanted to leave about 30 minutes. So does anyone have a question about cases that they work on? You can feel free to write into the chat or unmute, as Madison was saying, and tell Madison you want to be unmuted and talk that way. Okay, first question. Are there any unique questions you asked during the intake for a PDA as opposed to other inquiries? Yes. So there's, you have your basic background stuff, and for the most part, the intake is going to be similar to lots of other intakes. But you do want to pay special mind to like questions that are surrounding anxiety, and particularly questions surrounding what has been previously tried, like what other modalities, what kind of approaches, and how those things have gone. Um, it will vary depending on if the individual already has a diagnosis of ASD level 1 or not. If you're sort of reading a neuropsych that has like an ODD diagnosis in there or ADHD diagnosis in there, you would definitely want to ask more questions about the underlying anxiety or the underlying reason for some of the behavior with both parents and teachers if you're talking to them. Second question is, do you see similar resistances to parents accepting PDA diagnosis versus an ASD diagnosis? So for the most part, I would say no, because lots of parents are coming and saying, I think my child has PDA. Where I'm only starting to recently see, maybe for the first couple of times, I've seen that the diagnosis is being initially explored by the testing clinician versus the parent. And I've sort of seen some of the opposite where there are parents who are really insistent that it's PDA without having a full understanding of what PDA is, because they have said that every intervention they've tried or everything they've ever done has not worked before. And this is why I brought this up earlier, that is something that really needs to be explored with families, because sometimes it's not PDA, sometimes it's something else, or it's a level 1 ASD and there is comorbid anxiety. And in those cases, we're not going to completely overhaul our treatment approach. We might still lean into some more traditionally behavioral parenting approaches, which might be a better fit. So I think that it depends. It depends on the parent and the difficulties that their child is having, but I have not seen resistance to parents accepting PDA as the diagnosis. Does therapy length for PDA typically exist similarly in length to a child receiving ABA? You mean like per session? Whoever wrote this? I mean, you wouldn't be doing, if we're talking about session length for, like duration of therapy, 6 months to a year, it's depending on how impactful the PDA is on day-to-day life, right? Like if we're in a crisis moment, there's burnout, we needed school change, there's all kinds of things happening. It might be more intense, and then it might not be as intense at other points in time. It's less of a sequential approach like traditional ABAs where you see, at least trend lines over time of interventions having impact. For the most part, there might always be some need for consultation for years and years and years with PDA. Is medication for anxiety always required as part of the treatment package, or can it be treated without medication? It can be treated without medication, but for the most part, medication is a really good additive component of therapy for PDA, and something that if I'm doing an intake with a family and they have not yet done a medication consult, I will always refer them for one. It's their choice, of course, whether to pursue or not, but can be really like a really powerful addition to a treatment plan. Will an individual with PDA have difficulties with maintaining appropriate social boundaries? Yes. Not at the surface level. But as we get a little bit deeper, they will often either misperceive or have some sort of conflict that they can't resolve with either friends or individuals that they meet online. Back to what I was saying earlier about them being can be very fixated and wanting to be close to other people. In my experience, if they meet like a friend on some sort of social media account, it can be very like hard and fast. And there's a lot of like, talking and togetherness. And then suddenly once we get to a deeper level, the conflicts can't be resolved. There's some sort of misperception that happened and they can't resolve that. And then it's over. And things like that happen again and again and again. Is there formal training for clinicians looking to expand their skill set in PDA? Yes. So there are trainings through PDA North America, like I was talking about. I've done that training. There is also the UK Society's training, but I think now that the North America organization has one, that's the one that I would recommend as a really great foundation. And then they do a lot of specific other trainings, and then there are books as well that can help. Oftentimes with home ABA, we see siblings wanting to be involved in a session. How would you approach a sibling of a child with PDA if they wanted to be involved? I would say like it sort of depends on the siblings' relationships, right? Like if you're working on, like let's say you're sort of following the individual's lead and they want to work on like cooking something, and you've sort of planned to like, oh, we can look at recipes and choose one and then we'll go to the store and get the thing, so it's very individually driven. If the sibling is around and your client is amenable to the sibling being there too, they can join, no problem. Yes, we're going to share the PowerPoint, so you'll have that.
Yeah, I can
And
share that in the chat now.
okay, even better. And then I can also send some names of books and things like that. I think I meant to put that on here, but no. I will send some books, but the PDA North America website is a fantastic resource to start with. Is there a recommendation for group therapy for individuals with PDA or just individual therapy? It's mostly individual therapy to start. There are some great resources for older individuals, not for PDA. I mean, there's good like online support groups and things like that for PDA that I've recommended. It's not really group therapy; it's more like a support group. In the city, there is particularly for females this wonderful place called Felicity House. It's sort of like a meeting point for lower support need females diagnosed with ASD. There are some PDAers who are also a part of that group as well, but it's essentially like just a more of a structured, safe space hangout spot. There are lots of really good, particularly through the UK, support groups for young adults who have PDA profile. Next question. How did you get introduced to the world of PDA? Oh yeah, I talked about this a little bit at the beginning, but about 5 years ago, I had a family come to me and say that they read about this diagnosis and they felt that their child met the criteria. At the time, this family had hired a consultant from PDA North America and had pursued a more formal diagnosis through that. And I just was really engaged with this woman and wanted to learn more. And then I did a training from there based on her recommendations, and just been continuing to do trainings and attend conferences and read all the new things that are coming out about PDA since then. I also see a number of individuals who meet criteria for the PDA diagnosis, who have a more formal assessment done. And I work with a lot of families, as the quarterback I was talking about is a role that I typically take. Any other questions? I want to address something that was a little bit earlier about the ABA sessions, siblings, and also the duration of the therapy. An ABA session is going to look super different for a PDAer than it looks for, even a very like play-based naturalistic ABA session. So for example, we might have like individuals who are getting like session length as like 4 or 5 hours for their sessions with PDA, and that's because of a couple of reasons. For the most part, that would be recommended for individuals who are not engaged in like a full-time school program, right? So I think I mentioned before, like sometimes you could have these like online schools, and then the therapists are helping the individual access that and structuring their time and things like that. But more so than that, it is very rare that if you are an ABA therapist, behavior interventionist, BCBA, doing home-based or community-based work with a PDA, or that your whole time of your session is going to be super focused on skill building. For the most part, it's going to be a mixture of like breaks and waiting and offering choices. So it might take like a really long amount of time to get some traction and actually do something versus in more of a like, like a more traditional ABA session when you're there for 90 minutes or 2 hours and you know that you can structure the session the way that for the most part you want to. That's definitely like a very important thing. So if you are working with a family who suspects this and um they have an ABA team already in place, right? Like let's say they're working with an agency. It's really important that you make sure that the BCBA on that team is at least PDA informed so that they can do PDA informed supervision for the techs on the team. My suggestion for that, and what I actually do a lot if the timing works out schedule wise, is to overlap with their parent training. So if the BCBA is doing a parent training with the family once per week for an hour, I'll say like, let's all meet for once per week. And that is a really good and easy way to keep everyone aligned and keep parents informed logistically. Um, would the trainings through PDA North America be beneficial for ABA therapists or RBTs, or more so for certified licensed clinicians? I think they're beneficial for everyone. I do think that the more we engage in learning about PDA, not just about like what it is and how it presents, but also what we can do, the more that we will get people in the field who at least have an increased openness and understanding of how to treat individuals with this profile. Right now, there are certainly increasing amounts of professionals, and now at least there are however many more, 16 more that are here right now. But we still do run up against, BCBAs, psychiatrists, psychologists who really don't believe in the diagnosis. They do not have as much training in just ASD to begin with. And that can be really difficult for parents to navigate. Like you'll often hear from parents that they were, shot down by all these supposed experts who couldn't help them with their child. So I do think that the more information out there and the more we talk about this, the more that it will find its way into training for all clinicians, not just BCBAs and RBTs and technicians. Any more questions? Does anyone else have any other questions? Is there any data related to how many people have PDA? That's like a really good question. I don't know. I don't know what the percentage is of individuals who have like autism meet a PDA profile. And that's honestly what's like, it's not great about it not being included in the DSM. It means that our research is sort of lagging, and it's really important to be super informed about what you are consuming. I was just looking for a book, but I think that it's not here. I'm gonna send it. Actually, I'm gonna see if I could pull it up now, but it's essentially this book for a PDA roadmap in America. Let's see if I can find it. In the meantime, does anyone have any other questions?
Do you foresee on the wing of the last question, do you foresee there being more prevalence and potentially more, understanding with the more education and training that is being completed?
I
You know how
do.
I've seen with autism, how the more research that's been behind it, the more diagnoses there's been, and the more the field has grown. Do you see the similar thing being um, same for PDA?
I do. I definitely think that alongside our, growing inclusion of just neurodiversity in general and what that means and how we can, shift our expectations, not just from a therapeutic perspective, but just from a societal expectation. I think that the understanding for PDA will grow alongside that, particularly because we have more and more individuals who are coming of like adult age who are able to really talk very clearly about their experience and what it was like, and what helped, right? Like what helped and what didn't help, in the same way that we see, individuals talking about their experience with therapy, right? So we're always trying to grow and evolve and change. My hope is that this profile will either find its way into the DSM as a subtype of autism moving forward, or as its own standalone diagnosis. Um, I think that would be obviously really beneficial for research and, insurance coverage and all, therapy moving forward. I dropped in the chat the link to this book, Navigating PDA in America. This is a great book. It was just published in June of 2024, so it's really recent. Diane Gould, who's one of the authors of this book, is the director of PDA North America. That is the consultant that I first met all those years ago. She's wonderful. And this book is all about a framework to supporting children and adolescents and young adults through a therapeutic approach. And it specifically speaks to like America and our approach to education and things like that. I found it to be really wonderful. And if you click the link at the top of it, you'll see there's also a Understanding Pathological Demand Avoidance Syndrome in Children. That's also a really good book. I will link that here as well. And I would encourage everyone to get on the PDA North America listserv, just to, understand a little bit more, see their stuff. I was going to try and see, oh, this is the other book I wanted to link in here. This is Ross Greene's book, The Explosive Child. Fantastic book. So I would say, I hope that this provided a really in-depth approach to what PDA is, how it shows up, and how we can approach. And if you have any questions, please reach out to me. I've done tons of consultation on our cases internally. If you have a case you want to talk about, please let me know. There's one more question. What would be the first step? What would the first step be for a clinician who doesn't have experience with PDA for a family who brings up concerns? If the family brings up concerns and they do not have a diagnosis, please refer them for a comprehensive diagnostic evaluation. At MPG, we do have our neuropsychologists who are comfortable in assessing and diagnosing PDA, so it can certainly be done internally with us. After that, then you would really have to, decide if you felt confident enough with this and some books and things like that, developing a treatment plan for them. But the first step is always to get the clarity on the diagnosis. And I think that's it.
Okay. All right. I just posted in the chat the link for the CE quizzes. So pay attention to which quiz you're wanting. If you're a psychologist, click on the Psych CE quiz, licensed social workers, the social work, and if you're a BCPA or BCABA looking for the BACB CEUs, then click on the ABA CEU quiz. All right.
Right.
Well, if
Thank
there's
you,
no more
everyone.
questions that come in, thank you, Ariel, for presenting today, and thank you, everybody, for joining us. I will stay on for just a little bit longer to assist with any questions that do come in or any questions about CEs, but thank you, everybody.
Thank you.